Assalamu alaikum wa rahmatullah. Good evening, dear colleagues and friends. So we will come to the last, but not the least, session in 8 Quick conference. And I am honored and have a pleasure to introduce one of the eminent and elite and pioneer ophthalmologists in our area and worldwide. So let me introduce Dr. Mahmoud Ismail. Muhammad Ismail has completed his PhD in ophthalmology from university. So Dr. Muhammad Ismail has completed his PhD in ophthalmology from University of Alicante, Spain during December 1996, and master degree in ophthalmology and ocular surgery from the University Al-Azhar in 1989. Had the Bachelor of Medicine and Surgery from the same university. He is a professor of ophthalmology and head of cornea and refractive surgery unit at University of Al-Azhar, Egypt. Dr. Mahmoud is also awarded with many prizes during his academic work. He has published many papers in reputed journals and also participated in various national and international conferences. He is the president of Egyptian Ophthalmological Society. He is a visiting professor, University of Miguel Jimenez in Spain. Thank you, Dr. Mahmoud, for giving us the chance to be with us. And it's our honor and pleasure. And the floor for you, please. Thank you very much.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Muhammad Basha Al-Amri and all our colleagues from Mayom Academy. I think after the long day, we have to be very precise in our presentations, and I will try to open.
Everything is fine, Dr. Mahmoud?
Yes. Can you hear me, sir?
Yeah. Thank you very much. Yes, I can hear you very well.
I will start by some basic knowledge, first in the cornea, about the healing. The healing in any corneal injury, it starts by the epithelial plug, and the epithelial plug fills up to about 70%. And this, if it's open once again, like in a chronic ulcer, it gets healing by secondary intention. Secondary intention meaning that you have converted the case to a chronic case. Of course, the cornea had a lot of diseases. The most important, and today's discussion is about infectious keratitis. And in our course to explain the infectious keratitis, we have to know that there is a lot of vicious germs that can attack even intact epithelium, like in cases of acanthamoeba keratitis. Of course, as we all know, the history of contact lenses in the hot, humid climate, that's why in Florida and the United States, they have the highest incidence. Foreign body and pounds, water pounds are the most vulnerable people who are working in ponds. And it's characteristic by something very unusual. The manifestation is called ocular pains. As we all know, pain is not a plural, it's a single. But to emphasize about the horrible pain that the patient suffers, we call it ocular pains. And it's always unproportional. Unproportional pain, ulcer and serial injection and corneal edema with the hell of rapid deterioration. Small, tiny ulcer manifests the patient with horrible pain, and the ocular manifestation consequence with it. Healing, if it's in the periphery, you are lucky. If it's not in the periphery and in the center, like in this case, is very peripheral, and the patient ends by a faint opacity. This is very unusual, but sometimes it's very resistant. As we all know, the bioguanides and the neomycin with the chlorhexidine is the basic knowledge about And I insist on the neomycin because sometimes we don't find the bioguanides in the market. Unfortunately, in our zone, at least in Egypt, sometimes it's not out of stock. And sometimes we prepare the chlorhexidine by ourselves, and it's very easy. If you get any product, even mouthwash of like this one, in 0.3%, and you are diluted in 0.01% in polymyxin B, like our commercial eye drops in Egypt, Neopol. So you can manage until. However, if the region is central, that's the ugly part. And as you can see, the infiltrate is very huge. According to the ulcer is small, and the infiltrate is huge. And this is in cases of central part, it might take months to reach this situation, months even. Also in fungal infection, as you can see, this is beautiful creases, very colorful and very nice, but they are very vicious. This is the fungal ulcers and fungal infectious keratitis. Fungal infectious keratitis in our zone are very common with the fusarium, with the hyphae, and that's why it jumps from one part to another. This explains the satellites. And sometimes the less vicious, which is the candida, and it occurs in hot, humid complexion without foreign body even, but it needs to be have an ulcer in order to penetrate. And the following one is the aspergillus. Thank God it's not even here in Egypt. It's very rare in Egypt, but it appears with a coliform hyphae, and even the infiltrates, it's in coliform appearance also. And this is a typical fungal keratitis, the feathery appearance, the consolidated hypopion, and this is how it looks. And meaning of consolidated hypopion, meaning that if you turn out the patient's head, the hypopion stays the same, and the feathery look and the small satellites. And unfortunately, the patient can get the injury, the plant origin, and it may take even weeks until it manifests itself. And this is another resistant ulcer, cases with undermined edges. As you can see, the ulcer is here, but it contains contented and undermined edges more than the manifested ulcer. This is another case, as you can see, satellite LASIK surgery. The edge of the laser surgery was contaminated by fungal infection, and rapidly, after 2-3 weeks, it starts to have such satellites, as you can see. And obviously, this LASIK flap was created by non-septic microkeratome or blade. Also, it can mimic dendritic or herpetic. The only difference between this case of dendritic-like or herpetic-like infiltrates is the interlacing areas are hazy. In cases of pure herpetic or viral keratitis, the intermediate areas are completely clear. Also, it might have a very tiny ulcer and a huge stromal keratopathy. Like in a case like this, look at the ulcer is so small, so tiny, but the keratopathy is huge. The keratopathy is taking more than 2/3 of the cornea, while the ulcer is very tiny. And this is very typical of some of our cases. The treatment includes two main families: the conazole family, the fluoroconazole, itraconazole, or voriconazole, according to the zone where you're working, and the natamycin and amphotericin B, which is more to the candida. Natamycin is more to the hyphae type. And we don't forget the neomycin and chromphenicol as an adjuvant in cases of fungal infection. However, in cases of viral keratitis, we change the gear. We have two main, simplex and adeno. The adenovirus, you can start with giving topical steroid. However, in cases like this, you have to be very careful not giving any type of steroids. The adenoviral, or Apollo 8, as we call it, it comes in raids. You have a zone, infection zone, like in our 2 years ago in the in the north of Egypt, in the area of from Alexandria to Marsa Matruh, there was an epidemic of viral adenoviral, and you have to treat with steroid, otherwise it will leave some kind of a patient. This is an unlucky patient. He had an activated herpetic ulcer after LASIK, and this is a typical dendritic ulcer for originating from starting from the LASIK flap after taking some kind of steroids. This is also a deciform keratitis, and this is immune reaction, and it's more or less in children more than adults, and it occurs suddenly previous symptoms, just for and you find the keratopathy and deciform without any kind of ulcer. This also you have to gain topical fluorometholone to enhance the fluorometholone, dexamethasone, prednisolone. Fluorometholone, they are not weak. They are connected or concentrated in the cornea. They have low penetration, and they don't affect more on the intraocular pressure, and they have low duration form. However, the dexamethasone is intermediate. They act late, and they take some times, and they are more or less devoted to the intermediate uveitis. The prednisolone more and more prolonged, and the spikes, they have low spikes of intraocular pressure. However, they more or less confined to the posterior uveitis. During the COVID area, we have noticed some kind of conjunctivitis, which is a viral conjunctivitis, very rare. It's a pink-like hyperemia with tinge of blood in the secretion, and it resolves by topical steroids with mixture some of the mocofloxacin, and they don't have lymph nodes like other kind of lymphatic. Some cases, they are very query infection with a circular and infiltrates. At the beginning, we thought that this is acanthamoeba, but unfortunately, the patient swear that he never wore contact lenses. And after some time and taking more and more culture, we found that some cases we have mycobacteria, especially in debilitated patients. And this is a typical bacteria, and you have to treat it with azithromycin. So, in post-infectious keratitis, post-surgery, like in post-vitrectomy, when our colleagues doing posterior segment, they scrap the epithelium in diabetic patients with hypopyon. If you are, let us concise, if the patient in the second day manifests hypopyon ulcer, most probably staph or pneumococci. But if there is huge or rapid deterioration, unfortunately, this is the very vicious Pseudomonas. If in 1 week it appears for us, this infection, it might be a typical mycobacteria, and if it takes 2 to 3 weeks, this is most probably fungal infection. And this is the most common affection for it. Last but not least, I have been lucky to see in the last few months 3 or 4 cases of Terence mantle degeneration. I don't know why. I have just saw a couple of them from Terence and one case of very vicious Morin ulcer. I want to emphasize on both of them because they are completely different in managing, because secondary infection might toss off the case. And this is how to differentiate between one of them to another. The Terence is always bilateral, non-symmetrical, but always bilateral. However, the Morin ulcer are more unilateral. The inflammation in Terence marginal degeneration is hardly seen, and it's always superior. However, in cases of Morin's ulcer, the eye is horrible and inflamed and red, and there is also a very significant ulcer, and it can appear in any area from 360 degrees around the limbs. I think we have to stop here because I am sure that Dr. Amri, this is a long day, and I'm sure that our colleagues might need to ask something. And before leaving with you, this is a simple diagram of how to treat a dry eye if there is an aqueous deficiency or evaporative lid deformity. And please don't forget the Sjogren syndrome, either primary or secondary. Also, if there is local problem like hematopoietic gland dysfunction, post-LASIK, drug like antidepressants or thyroid drugs. Also, there is some people, they lack blinking. People are working long hours on computer screens and smartphones. They lack blinking, and this is one of the very, very noxious cases of dry eye. I would like to thank you once again, Dr. Mohammed Al-Amri, and we are looking forward also to see you once again in Cairo, and please save the date. It will be the 24th to 26th of April, and we would love to host also in the same place, in the same center of Cairo, and we would love to have you once again with us, Dr. Mohammed Amri. Thank you very much.
Dr. Mahmoud, thank you very much for this excellent and comprehensive presentation. It was a great to have you also with us. Maybe we can have only a few questions, if you don't mind. I know also
Please.
you are wearing like you are still, I think,
I'm still in clinic, actually.
Yeah, in the clinic. I can see that, so I don't want to make a lot of burden, but it was a pleasure and to have you, and it is an honor also to be with us in this and to have
Thank
you
you.
as a guest of honor in our conference. Dr. Mahmoud, sometimes do you think we need just to take all the measures that whenever we are saying to diagnose it is viral or it's bacterial, to have scrubbing of the ulcer and these all measures, or you are going to depend, empirically the treatment according to the history and taking in consideration the information you have just shown with us now?
Dr. Amri, let us be honest with you. I address to all doctors, they have to depend on their clinical sense, because from the time of scraping, if you are lucky, not less than 3 days until you get the right answer. In such 3 days, a lot of things can happen, especially if you have an aggressive, noxious Pseudomonas, for example, or horrible acanthamoeba, and you have given the patient topical steroid, like sometimes it happens. So you have to depend on yourself, your clinical sense, and as you said, the history. History is crucial in these cases.
There is another question, Dr. Mahmoud. You mentioned in adenovirus subepithelial infiltrate I think that we are treating by steroid. Is there is any chance now for cyclosporine or Zedra to treat these cases because instead of using of steroid?
In resistant cases. But if you use fluorometholone from day one with a reasonable dose of 3 times per day, with lubricants and a systemic antiviral, you don't give, in cases of adenovirus, you don't give topical antiviral. You give systemic antiviral. You give topical steroids, lubricants, and mild antibiotic once per day, like moxifloxacin, for fear of secondary infection. But if you give a reasonable dose of topical fluorometholone, believe me, in few days you get a rapid improvement.
In case of chronic, sometimes you treat the patient and he improved, but he came with you with the subepithelial infiltrate after a while. So are you going to give a chance for steroid?
Yes, or steroids combined. In such cases, I agree with you. You have to add cyclosporine, but unfortunately, the chronic cases are very, very tedious, and they take time, and they affect the visual. I had a girl who had this adenovirus, and it took her about 1.5 years to improve. Actually, it was long time.
The majority usually within 6 months.
6 months, yes, but I don't know if you have an epidemics epidemic break of adenovirus. You have seen it in here in the north of Egypt. Every couple of years we have an epidemic, and it's always it's very curious, Dr. Muhammad. It's always in the same region, from Alexandria to Marsa Matruh towards Libya, in such area, and it always at the end of the summer. Very curious, and we don't know why. It repeated itself every 2-3 years. It happens once, and it's an epidemic spread. Everybody, in the end of the summer, everybody in the north, and everybody comes. Very easy to get contagious.
But I think the people get now. I mean, all the doctors get about information, and they are well known about this one, so they can manage
now,
it easily.
Yes, now they know. But the viral conjunctivitis of post-COVID conjunctivitis, we have seen it a lot in Egypt, but it was reported in one of the studies, as I have shown to you. We were underestimating it.
Dr. Mahmoud, we cannot, we will continue with you hours and hours, and I know it will not finish. I would like to thank you for accepting our invitation. Actually, I was enjoying being with you in last Egyptian Ophthalmology Society conference. It was a great.
You promised to come next year. You promised.
First of all, we will have you, as you know. We will have you, inshallah, in Miyom, inshallah, in October this year, and you will enjoy. Then after that, we will decide about the next year. We will be together, inshallah. We'd like to welcome you and thank you very much for this, giving us this opportunity to learn from your experience, and have a great day. Thank you very much, and thank you. Thanks a lot. At the end, I would like also to thank all dear speakers who participate with us in Miyom during the last 2 days. I'd like to thank also the management, all dear colleagues, those they prepared the scientific program with us. And I would like to thank Dr. Fatma for her support to make this event. And I would like to announce also that the CME accreditation will be ready after the meeting by a few weeks, and it will be calculated according to the time you spend in the sessions. And I would like also to welcome you to first Breast MENA conference and fifth Miyom conference that will be from 19 to 21 of October 23. Thanks a lot, and good night. Assalamu alaikum wa rahmatullah. Alhamdulillah Rabbil Alamin.